high-risk lesions. So there's sort of two categories of high-risk lesions. There's a lesion that we consider high-risk now because you've had this diagnosed on a core biopsy, and we know that there's a significant possibility that we might actually find cancer if we go to surgery and take more tissue around that area. That's a little bit different from thinking about something as high risk in the future, which is a change that you have in your breast tissue that tells us that over your lifetime, you're at higher risk of getting breast cancer than somebody who doesn't have those changes in the breast tissue. And so sometimes if you get a report from your radiologist, you've had a biopsy, sometimes these terms can be used a little bit interchangeably, and it becomes important to understand, is this high risk because I need a surgical biopsy to make sure I don't have cancer, or is this high risk because this tells me something about my future risk? So these are the classic high-risk lesions, and these lesions actually fit into both categories. They're kind of high risk for the short term and high risk for the long term. These lesions are atypical duct hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. And so if you think back to that cartoon that I showed you at the beginning, with the breast tissue is made up of milk glands and ducts. So again, we call the glands lobules, and the ducts, of course, are ducts. And so these lesions are changes in the cells that stay inside either the duct or the lobule. They're not spreading out into the fatty tissue of the breast, so they're contained inside. And they're not cancer, but when a woman has these cells, we know that she's at higher risk for cancer in the future. And so in the program, we try to educate women about that level of risk. And so if we look using this cartoon here, Brittany said that the average woman has a 12% lifetime risk of getting breast cancer. So that's on the left-hand side. If we have 100 women in the gray picture, the average risk, 12 out of 100 will develop breast cancer in their lifetime. If we look at groups of women with either atypical ductal or lobular hyperplasia, if you take 100 women with those changes in their breast tissue, about 15 to 20 of those women will develop breast cancer over their lifetime. And then on the far side, if you take 100 women with lobular carcinoma in situ in their breast tissue, about 20 to 25 of those women will develop breast cancer in their lifetime. So these are lesions that put women at higher risk, generally up to or above that lifetime risk of greater than 20%, as Brittany mentioned, but they're certainly not as associated with as high of risk as having an inherited mutation, where Brittany just described those women have a 50 to 80% lifetime risk. So we are talking about increased risk, but not quite as high as hereditary risk. These are these data that we have to understand of the risk associated with these lesions comes from very large series of where women with these lesions were followed over many, many years at different institutions, and then the investigators reported out how many women developed breast cancer. So the largest group of women with atypia, those atypical ductal or atypical lobular hyperplasia, the Mayo group has a very nice research program around this. And again, that's where these numbers come from. And when I talk to a woman about her risk with atypia, I like to break it down into each year because it's a steady risk over time, and that risk is about 1% per year. So if you say, what's my risk in 20 years? It's 20%, but it's easier to break it down into that 1% per year, I find, when we're thinking about, okay, what do I need to do today? So what does this mean? This means that a woman that has ADH or ALH, every year when she comes in to get her mammogram, there's a 99% chance she won't have breast cancer and a 1% chance that she will. So it's important to keep coming for that mammographic screening, but again, we don't have to think about this as a huge amount of risk all at one time. Similarly, for lobular carcinoma in situ, we again understand how many women will get breast cancer with this lesion from large groups of women that were followed over time. This is a large group of women with LCIS that we followed at Memorial Sloan Kettering Cancer Center in New York City when I was there. And in this group, we see that risk is a little bit higher than the atypical ductal or lobular hyperplasias, and this risk is about 2% per year. So again, when I'm talking to a woman with LCIS, every year when she comes in for screening, there's a 98% chance she won't have breast cancer and a 2% chance that she will. Now again, I can make it sound big and I can say you have a 25% chance of getting breast cancer, but that's not 25% today. That risk is a steady risk over that woman's lifetime. So what about the short-term risk then? What does that mean? Well, the short-term risk really comes down to this phenomenon of when you have a needle biopsy, you have an abnormality on the mammogram, the radiologist does a needle biopsy for us, and he takes out these little fragments or pieces of tissue, and then we ask our pathologist to tell us what do those pieces of tissue represent. And sometimes it can be hard, like putting a jigsaw puzzle together without having the box to know what that picture is supposed to look like when you're done. And so sometimes these fragments, they can't tell if these fragments are simply atypical duct hyperplasia, or do these fragments actually represent early breast cancer, that DCIS, where the abnormal cells are still inside the milk duct. So this would be an example if the rectangle, if that's the piece of the tissue that's taken out by the needle biopsy, by the core biopsy, and that's all that the pathologist has to look at, it's not always so clear what is the diagnosis. And so for women with ADH on a core biopsy, we know that if we take those women to surgery, that about 15 to 20% of them will actually have a breast cancer at that time, that we just did not have enough information from that needle biopsy to diagnose. And so we call that underestimation. And so that, again, is this short-term risk associated with lesions like ADH, where we know we need to go to surgery to make sure that there's no cancer at that time. Once we've clarified that there is no cancer, then we talk about the long-term risk associated with those atypical lesions. Now, we'd really like to not have to do unnecessary surgery on 75 women to find cancer in 20 or 25, and so we're doing research around this area, trying to use artificial intelligence. We all know computers are getting smarter than we are, and so we are using artificial intelligence, which you'll hear about later from Dr. Lehman in her work, but we're trying to use mammographic data images, pathology images, and then our clinical risk factors that we collect from women like yourselves in our program to see if we can generate computer algorithms that actually help us identify which women with ADH really need to have that surgical biopsy and which women don't, so we can try to avoid those unnecessary procedures. So lobular lesions, again, lobular lesions are these same cellular changes, but they're now in the milk gland, not in the milk duct. And the two main flavors, again, are atypical lobular hyperplasia and lobular carcinoma in situ. And they're just sort of cousins of each other. The ALH means there's some abnormal cells in those milk glands, but they're not quite filling or distending all of those glands. And when you get to where all those glands are full and distended with these cells, that's when it moves up to LCIS. Okay, so it's just a spectrum of changes in that milk gland. Lobular carcinoma in situ has an interesting history. Obviously, it has the word cancer in the name, but I'm telling you it's not cancer. I'm telling you that it's a risk factor. So how did we get here? Well, I've been studying this lesion for most of my career, so I can tell this history, anytime, any place. So the lesion itself was first described by Dr. Ewing, who was a pathologist who worked at Sloan Kettering in 1919. He didn't know anything about this. He just saw it in some breast tissue and took a picture of it and published it in a book. He didn't even name it. He just thought it looked interesting, so he took a picture of it. In 1941, two other pathologists at Memorial, again, Foote and Stewart, they started seeing this lesion in breast tissue, and they knew that Dr. Ewing had taken a picture of it but hadn't described it. They actually gave it its name. They actually were the ones to coin the term lobular carcinoma in situ, and they were concerned that women who had this lesion in the breast would develop breast cancer if they didn't have surgery. And so at that time in the 1940s, if you were found to have these cells, it was recommended that you have a mastectomy to prevent the development of breast cancer. Well, then what happened over the next 40 years or so is that other pathologists started to become interested in this lesion, and they went back to their archives. So many of you know when you have a breast biopsy, that tissue gets put in a wax block. They look at a couple of sections of that wax block to make the diagnosis, but the rest of that wax block goes and is stored away for years and years. And so these pathologists, Rosen and Hagenson, they went back and they pulled a bunch of those old blocks from the archives, and they looked through them to identify women who had LCIS but maybe wasn't discovered at that time, or people weren't thinking about it. And then they looked over time and they said, okay, how many of these women developed breast cancer? Now again, this was back in the 50s and 60s, where if you lived in New York City, you stayed in New York City, you didn't go anywhere. So they were able to actually still find all these women that had these biopsies to see how many of them developed breast cancer. And the interesting thing was that over now a 20-year period of time, only 20% of those women had developed breast cancer. And so they said, well, if this was really that dangerous, if this is really going to turn into breast cancer, we would have expected more than 20% of women to have developed cancer over 20 years. The other thing that was interesting was that the women who did develop breast cancer, half of them developed it in the same breast that had the biopsy, but half of them developed it in the other breast. And so again, that raised a question mark in their head. Well, if these cells are really so risky, why were women getting cancer in the other breast? And then the third piece of information, which was interesting and unexpected, was half of the women developed lobular cancers and half of the women developed ductal cancers. And so again, calling into question this idea that it was these cells that were the problem, because how would you get a ductal cancer from lobular carcinoma in situ? So as these pieces started to come together and people started to consider what they really meant in the late 90s, that's when we stopped thinking about LCIS as something that needed to be treated or removed, and we started thinking about it as a risk factor for breast cancer, just as having a family history is a risk factor for breast cancer. And so these are data from a large population database here in the United States. It's called SEER, and all major cancer centers report their data to SEER so we can see trends in diagnosis and treatment. And so this is a compilation of now 19,000 women with LCIS reported to the SEER database between 1983 and 2013. And what this shows is this very nice drop-off in the use of mastectomy. So as I told you, as we learned over time through the 80s and into the 90s, that we didn't need to treat LCIS, we needed to counsel women regarding their risk. You can see the very nice drop-off in the use of mastectomy and the increase in the use of just simply surgical excision to say all you have is LCIS. And again, from that data set, the risk prediction, the risk of getting breast cancer has remained very steady over all of these years. So I told you back when Foote and Stewart and the other pathologists started looking that it was 20% over 20 years. And here in the SEER database, so modern women like you and I getting LCIS at 20 years, the risk of developing breast cancer was 20%. So again, if you want to think about it in yearly increments, this data suggests again about 1% per year risk. Now, the other thing that I'm very passionate about is that we actually have medication that reduces that risk of breast cancer. We call it chemoprevention. I understand that's an ugly name. Nobody likes the word chemo in there. But these medications do reduce the risk of developing breast cancer, and they work particularly well in women with atypical ductal or lobular hyperplasia or in women with lobular carcinoma in situ. So this is just data, again, from that large group of women at Sloan Kettering showing the likelihood of developing cancer over time. If you did not take chemoprevention, you were in the blue line. If you did, you were in the red line. And so we see the numbers at the bottom. With no chemoprevention, the likelihood of developing cancer at 5 years was 11%, and with chemoprevention, the likelihood was 3%. So it cuts that risk by more than half, okay? And why does it work so well in women with lobular carcinoma in situ? Well, because if a woman with lobular carcinoma in situ is going to get breast cancer, she is almost 100% likely going to get an estrogen receptor positive breast cancer. So you've probably heard these terms. We talk about, is your breast cancer ER positive, ER negative, or is it hormonally sensitive or not? So women with LCIS get ER positive breast cancers if they're going to get one. Those of you who know me know that I knock on wood a lot. So if they're going to get a cancer, it will be ER positive, and that's what these medications prevent. They prevent the development of ER-positive breast cancer. So that's why they work particularly well in this group. So again, just to summarize, the risk, what is the risk with these lesions? Again, for the atypical duct and lobular hyperplasia group, it's around 15 to 20%, and for the LCIS group, it's around 20 to 25%. Now to switch gears a little bit and talk about breast density. We have a wonderful breast imager in the audience, and so I hopefully won't say anything that she disagrees with. But I just, again, like to break it down into simplest terms. So these are the 4 groups of breast density. Breast density is how dense do your breasts look on mammogram. It's not how do they feel when we examine you. It's not lumpy bumpiness when we examine you. It's how does the tissue look on mammogram. You can see the 4 categories, starting from very fatty breasts on the left, going all the way over to extremely dense breasts on your right. Most women who come for mammograms are in the middle. They're in the category 2 or category 3. You can see that accounts for about 80% of women having screening. About 10% of women have fatty breasts, and about 10% of women have the extremely dense breasts. So what does this mean? Well, having extremely dense breasts makes it harder to read a mammogram. You can see that if your breast looks like that complete whiteout, that it might be hard for Dr. Lehman and her colleagues to see something in there. And so that's when you hear about reduced mammographic sensitivity and the numbers along the bottom there. How likely is it for the mammogram to find your cancer? But we also know that there's some other implications to breast density. So breast density legislation is now is here to stay. So as many of you know, you get these letters. If you have dense breasts, meaning if you're in category 3 or category 4, when you have your mammogram, you get a note at the bottom of your report that says that you have dense breasts and that you should discuss supplemental screening with your doctor. Now, unfortunately, the most appropriate choice of supplemental screening is not entirely clear. And when I say most appropriate choice, again, we're balancing risks and benefits of screening, because the more we look, the more we find, but it's not always cancer, so we have a lot of unnecessary biopsies, which also leads to a lot of anxiety, as many of you know. So there's a lot of work going on now. Well, should women with dense breasts have ultrasound? These are the least expensive, but they're actually the lowest yield. They have much more false positives than true positives. What about MRI? Well, MRI is the most expensive, but it's actually has a higher yield than ultrasound. So if you have an MRI biopsy, that biopsy is more likely to be cancer than that ultrasound biopsy. But the correct answer here is not the same for every woman, okay? And the correct answer is, again, not so clear in our literature and in our research at this point. And so we continue to look for new and better ways to do breast cancer screening, particularly in women with dense breasts. And if you come into our program, we talk about the pros and cons of all of these choices. But, so that's the density kind of making it harder to see a cancer if it's there. But the other piece about density is, we've heard this, that breast density is a risk factor for breast cancer. And so here's where I think it's particularly important to be clear about what does that mean. Again, we have those 4 categories. It's only the category 4. It's only the extremely dense, so only about 10% of women. It's this category where the density itself is a risk factor for breast cancer. If you're in the middle, in that 2 to 3, that density does not put you at significantly higher risk of breast cancer. It's only this 4 category. And that risk is if you compare women in the density 4 to the density 1. So compared to a woman with completely fatty breasts, a woman with extremely dense breasts has an increased risk of breast cancer that, if you're reading in the literature, they might say it's 4 to 5 times higher. But again, that's comparing the 2 extremes. Most women, as we said, are in the middle. Most women are in this 2 to 3 range. And so you can see across the bottom there, if you use category 2 as what we call the reference, and then you look at the increased risk to go into category 3, into category 4, the risk goes up a little bit, yes, at 1.2, 2.1, but it's not skyrocketing up into those, like, again, coming back to the hereditary risk, the 50 to 80%, and it's not even as high as the lobular carcinoma and Situ risk. Okay, so we have to keep all of these risk factors kind of in order in our mind. What does it mean? So again, here's another way of looking at this. Absolute risk, that's what you care about, is what's your risk of getting breast cancer. Women who have had biopsies before but no atypical cells, again, about 12% risk. Women who have the LCIS or the atypias at the bottom, again, 15 to 20 or 20 to 25%. And the dense breasts are sort of somewhere in the middle. And here's just another way of looking at that graphically. Again, women with LCIS in the yellow bar, this shows 12% at 10 years. At the very bottom, the kind of ugly green, that shows about 2% risk at 10 years. And women with dense breasts are sort of in that same level of risk right there with those three bars that are together, which is people that have had previous biopsies but don't have any atypical cells or any abnormal changes. So again, density is important, but I think we get sometimes a little too alarmed about density when we're thinking about breast cancer risk. What determines breast density? This is an area of ongoing investigation. Does it relate to other risk factors? We're pursuing that as well. We know that some women with dense breasts, their breasts will get less dense with age, and that's a good thing. We like to see that. But other women still continue to have very dense breasts even into their 60s and 70s, and so we're trying to understand those differences. And is breast density a modifiable risk factor? If you have extremely dense breasts, can we do something about it and reduce that risk? And again, that's the subject of some of our research that you'll hear about later this morning.